Hello, this is Dr. Ed Kim, and I'm here with Dr. Ria Hiroshi, one of our associate program directors, and we're going to talk about a very important process called the handoff. Excuse me.
Right. So a handoff is the definition of a handoff is when you hand off the care of your patient to another provider. That's going to happen to you multiple times a day, many times a week, and during your entire rotation. Why do you have to hand off care? Well, because you have to go home at some point. The problem is that discontinuity of care represents a real patient vulnerability. And the reason is if you have miscommunication or lack of information transfer, that's going to hurt the patient. That's been clearly shown over many studies that miscommunication is the root cause of many preventable errors that cause significant harm. That's why we have to concentrate on how we're going to minimize this vulnerability and how we're going to minimize the danger to our patients. And that's through the sign out process. And the sign out process is a communication vehicle in which you are going to transfer the essential information to another provider so that they can take safe care of their patients. The elements of a handoff and sign out have been really well established throughout other industries. Really high risk industries such as air traffic controllers, railroad dispatches, other things have shown that there are certain elements of the handoff that are critical to really successful and safe handoffs. The most important thing that these industries have shown is that you have to follow a template and there has to be a structure. You can't just wing it every time you hand off a bunch of planes in the air or you hand off railroad cars that are going in opposite directions. You have to follow a structure. The other important elements is that you have to minimize interruptions. If you interrupt this process by having nurses come in or answering your page, you're going to make an error. A third element is it has to be face-to-face. It has to be a verbal update. A sign out is inadequate if all you're going to do is email someone or leave a list lying on your call room bed. That is not a sign out. That's actually not high fidelity, and you can't have any interactive questionings. The communications mode has to be in a way where the receiver is interacting very much actively with the sender of the information.
So, I've heard a lot of that comparison, Rio, with the idea of like a fast food restaurant where you go in and you order something and they say it back. Is that part of what you're imagining?
Yeah. So every time you order to go order at a Chinese restaurant, what do? They always read back, right? When you get an important lab result, they make you read it back. And so read back is one way to ensure accuracy so that the Chinese restaurant will have what you're ordering. Now, read back is essential but not sufficient. Reading back is more like parroting. But you do need to go beyond that and ask questions, ask clarifying questions. If you're the receiver of the information, if you're getting sign out from a moonlighter and you don't understand the rationale or what happened, you have to interrupt them and you have to ask the question. Similarly, if you're handing off information to somebody else and they're not asking any questions, you know by definition that is an inadequate sign out. So it has to be a two-way street. And the problem with it is that even if you think the information is getting through, sometimes the information is not getting through.
Getting through to people is not so easy, is it?
Right. So there's a famous quote by George Bernard Shaw, which actually one of our Grand Round speakers gave the other day. And the quote is, the single biggest problem in communication is the illusion that it has taken place. And there's a lot of things that has to do with the psychology of miscommunication.
Yeah, what are some of the challenges that we face?
Yeah, so one of the things that we all do as human beings is we overestimate our ability to communicate something, and we overestimate the understanding of the other party. So senders of information systematically, this is human nature, overestimate how well their messages are understood by listeners. Psychologists call this the egocentric heuristic. And it actually, after the communication, senders assume that the receiver now has the same exact knowledge as they do, which is often not true. And in fact, interestingly, ironically, this worsens with the personal familiarity of the receiver. So if you're friends with the resident, or if you've seen incidents, I'm sure you've experienced incidents with your friends or spouse where you assume you said something in a manner that's understood by the person. but that information was completely misunderstood.
Sometimes with significant consequences.
Right, and in the consequence of doing this during a handoff is patient harm. There was a study in which pediatric residents were observed doing handoffs, and then the sender and receiver were separated, and they were asked what the most important piece of information about a particular patient was, and see what the correlation was between the sender and the receiver. It only correlated 40% of the time.
So 60% didn't didn't agree on what was the most important thing that was on the sign out, really.
Which is scary. And
Yeah.
so that's why I think we have to make sure that, number one, we follow the structure. Number two, that there's not only readback, but an interactive questioning during the handoff. And again, we have to make sure that the fidelity of the information is passed on, and that the rationale for each action that you're supposed to do for each particulation is passed on.
So so when you say rationale, you mean that you don't want a bunch of to-do lists or boxes that are things that the person who's coming on is supposed to do.
Too often what happens is that you have, and this happens all the time on rounds, you have a list of check boxes. You put a bunch of boxes next to your sign-out list, and you say, get this, get that, and that, check CPC, check CT scan, all these things. Now, if you're doing a sign-out, that's a completely inadequate sign-out. And just to give examples of that, if you have a sign-out that says, check a CBC on Mr. Jones, please, and then at 6 p.m., and then make sure you order a CT scan of the abdomen on Mrs. Smith, that's a task list, and that's, again, a completely inadequate sign-out. What it should read is, check a CB on Mrs. Jones because the crit went from 26 down to 23, and check it to make sure it doesn't go below 20. If it does, call 2 units, call Dr. Kim, and ask him what we should do next, whether we should go to the IR or whether they should go back to the operating room.
I mean, this is also included. You're talking about what kind of operation they had and all this other stuff.
Yes.
Is that right? That's what you're going to discuss with the
IPASS? Exactly. So the IPASS, IPASS, is a mnemonic that's used throughout our hospital, and it has to do with just, again, establishing a structure for each patient that you sign out, and making sure that you keep all the elements. I stands for illness severity, whether someone's stable, whether someone's unstable in the ICU, whether you really have to watch out for them transitioning to something. So I has to do with how much attention or how much you anticipate this patient giving a particular problem. P is for patient summary. That has to do with every patient. You have to summarize what happened, what operation they had, how far out they are, what's been going on, just the critical hospital course elements, and what's the ongoing assessment. A is the action list. This is your to-do list and your timeline. But again, this has to be followed by the S, which is situation awareness and contingency planning. So the action list and the contingency planning has to be done at the same time. So again, if it says CT scan on Mrs. Jones, it has to be CT scan on Mrs. Jones. We're looking for a fluid collection because she's febrile. If you see one, call IR to drain it, and call Dr. Harris that there is a fluid collection. Otherwise, that action list, that task list, is an inadequate list. And finally, probably the most important S is the synthesis by the receiver. That the receiver actually summarizes what was heard, asks questions, restates or readbacks the key action and to-do items, and make sure that everyone's on the same page. So if you follow the structure of IPASS, you should minimize some of the gaps in the handoffs that we've seen, and hopefully maintain really safe care of your patients even when you're not here.
Okay. So just kind of to summarize, IPASS, basically you're just explaining to the person who's coming on whether the patient is sick, not sick, on trajectory or off trajectory, what their background information was, what needs to be done, and what are some of the things they should anticipate. And then most importantly, at the end, you're saying the receiver has to engage that information and demonstrate to the listener that they understand what's going on.
Yeah, and with practice, this will become rote. This IPASS, you'll just do it on every patient, every time you sign out, etc. One thing that you do have to take into account is the level of the training of the receiver. So if you're signing out to a chief resident, it's a different thing than if you're signing out to a medical student or intern. So really figure out exactly how much detail and what are the rationale you have to do, but make sure that the information is critical.
You know, it also sounds like the sign-out process is also really a good educational tool in a way, because it allows the person to basically summarize, but it forces the person who's signing out to summarize for themselves, their entire service basically.
That's exactly right. So the handoff is both a teaching and learning opportunity. Use a handoff when you're a junior resident to take that opportunity to learn, to really figure out the rationale of the resident of why they're doing it.
Okay, thank you so much for listening, and we'll see you next time.